This case study was selected during our third week practicum in male medical ward. Focuses on a 37-year-old male with chronic kidney disease, or also known as CKD, complicated by fluid overload and severe hyperkalemia. It aligns well with our complex nursing practicum objectives that highlight the importance of vigilant assessment, fluid and electrolyte management, area support and prevention of complications in critically ill patients. According to Diabetes and ESA 2024, CKD is a progressive loss of renal function that leads to impaired fluid and electrolyte regulation, making patients vulnerable to life-threatening metabolic imbalance. You may ask why the case is challenging. Because it includes multiple organ systems that are affected, and at the same time causing it requiring rapid interventions, strict biochemical monitoring, and coordinated multidisciplinary care.
This case study involves a 37-year-old male who is currently admitted to the male medical ward at Sarawak General Hospital. He has a history of long-standing chronic kidney disease and hypertension. Over the past year, he had several hospital admissions, including an ischemic stroke, a sudden unexplained collapse, and his most recent admission on the 23rd November when he presented with shortness of breath. During this admission, he was initially managed in the ICU for 1 day before being transferred to the ward for renal management and monitoring. For this admission, his main complaints were shortness of breath and severe pain in both lower limbs, which was associated with grade 3 pitting edema. The pain was severe and constant, rated 10 out of 10, and significantly limited his mobility. He also appeared weak, pale and lethargic, with very minimal urine output, indicating worsening renal function. But he doesn't report any chest pain or fever. In terms of aggravating factors, his pain worsened with movement, while his shortness of breath was aggravated by fluid overload, metabolic acidosis, and hyperkalemia secondary to CKD. His pain was relieved by sleeping or resting, and his breathing improved significantly after administration of high-flow oxygen. Moving on to the history of present illness. The patient was brought to the emergency and trauma department due to worsening shortness of breath. On arrival, he required high-flow mask oxygen at 15 liters per minute, indicating a moderate respiratory distress. After stabilization, his oxygen therapy was gradually reduced. He was stepped down to the venturi mask in the ward and is currently maintained on nasal prong oxygen at 3 liters per minute. On examination, he was noted to have grade 3 bilateral lower limb edema with severe pain. His past medical history includes a long-standing chronic kidney disease, which likely contributed to fluid overload and electrolyte imbalance. He also has poorly controlled hypertension, which may have accelerated the progression of his kidney disease. Although he had a previous stroke in 2024, he currently has no residual neurological deficits. A prior episode of sudden collapse was also noted, with no clear cause identified. Moving on to the physical assessment. On general examination, the patient appeared pale, lethargic, and fatigued. Respiratory assessment revealed dyspnea with crackles, requiring oxygen support. Cardiovascularly, he is a non-hypertensive patient and was at high risk of cardiac arrhythmias due to severe hyperkalemia. Examination of the extremities showed grade 3 bilateral pitting edema with severe lower limb pain. Neurologically, he was alert and oriented, while renal assessment showed reduced urine output. Next is clinical examination results. His blood investigations showed severe anemia with hemoglobin progressively dropping to 5.2 grams deciliter. His white blood cell count was elevated while platelet levels remained normal. Renal profile revealed markedly elevated urea and creatinine, consistent with advanced CKD, although some improvement was observed with treatment. His potassium was initially critically high but improving following management. Other findings included low calcium, magnesium, and albumin, reflecting chronic illness and poor nutritional status.
Next, we move to the disease process of chronic kidney disease, which is CKD. CKD is a condition characterized by a permanent deterioration of kidney function with a reduced glomerular filtration rate, or GFR. As GFR progressively declines, the kidney are unable to extract excess water and sodium effectively, leading to salt and fluid retention. This fluid retention contributes to fluid overload and hypertension, which are common clinical manifestations of CKD. Diabetes mellitus is the leading cause of CKD, followed by hypertension, both of which cause long-term damage to the renal structures. The progressive decline in GFR in CKD results in impaired fluid balance and increased fluid volume in the body. This table shows the interpretation of GFR levels used to classify the stages of chronic kidney disease. As GFR progressively decreases from the early to advanced stages, the kidneys become less effective in filtering waste product and excess fluid. In the later stages of CKD, a significantly reduced GFR is associated with complications such as fluid overload, electrolyte imbalance, and also hypertension. Therefore, this table helps us understand the severity of kidney damage and guides clinical management. Now, we move on to the pathophysiology of chronic kidney disease. Normally, the kidneys filter blood, removing excess water, sodium, and potassium, while maintaining fluid, electrolyte, and also acid-base balance. In CKD, nephrons sustain damage. However, as nephron loss continues, the glomerular filtration rate, or GFR, reduces, and the kidney's ability reduces to eliminate waste water and electrolytes. So, it will impair the tubular functions that will prevents effective urine concentration and regulation of sodium, potassium, and water. Sodium and water retention activates the renin-angiotensin-aldosterone system, further worsening fluid overload, which can lead to hypertension, peripheral edema, and also pulmonary congestion. Potassium excretion declines, especially when GFR drops below 30 ml per minute, causing hyperkalemia. Metabolic acidosis also develops as damaged kidneys fail to excrete hydrogen ions, shifting potassium from cells into the bloodstream. Medications like ACE inhibitors, ARBs, potassium-sparing diuretics, beta blockers, and NSAID can further worsen hyperkalemia. Elevated potassium affect the heart electrical system, causing ECG changes, arrhythmias, and also muscle weakness. In advanced CKD, with GFR below than 15 ml per minute, the kidneys can no longer concentrate or dilute urine, making fluid overload and hyperkalemia more severe. Therefore, in this patient, advanced chronic kidney disease causes a marked reduction in kidney filtration, leading to fluid, potassium, and waste retention. Severe hyperkalemia occur due to impaired potassium excretion and was worsened by metabolic acidosis, which caused potassium to shift out of cells. Fluid overload results from reduced urine output and improved water regulation, presenting a shortness of breath and bilateral leg edema. Hyponatremia is mainly delusional due to excess retained fluid, while lethargic and uremic symptoms are caused by toxin accumulation. Therefore, urgent dialysis was initiated to correct fluid overload, metabolic acidosis, and also life-threatening hyperkalemia.
Hemodialysis is a treatment to filter blood when kidney are not able to remove waste products, extra fluid, and excess electrolyte. On 23 November, hemodialysis is initiated urgently due to patients show signs of symptomatic uremia, such as reduced consciousness, which is unable to speak in full sentence, and lethargic. Hemodialysis was being continued to remove fluid and potassium from body as patients present with bilateral pedal edema up to knee, facial puffiness, and high potassium with 8.2 mmol per liter detected in blood. Total fluid extraction on 24 November is 1.5 liter, meanwhile on 25 November is 3.4 liter. On 24 November, patient was alert and the GCS is 15 out of 15 within 24 hours. Facial puffiness and edema at bilateral lower limb was reduced after 24 hours. Potassium level also improved from 8.2 mmol per liter to 4.9 mmol per liter after 4 days. However, patient experienced acidosis breathing, which might indicate severe metabolic acidosis. Moving on to the pharmacological management, the first one is for the treatment of hyperkalemia. The first medication is 10 ml of IV calcium gluconate in 10 minutes. This is for cardiac protection in hyperkalemia. The second medication is the mixture of 50 ml of IV dextrose 50% with 10 units of actrapid in 30 minutes. So the actrapid is to shift potassium into cells, meanwhile the dextrose 50% is to provide glucose to prevent hypoglycemia. So the outcome is on 27 November, potassium level improved from 8.2 mmol per liter to 4.9 mmol per liter after 4 days. The second treatment is for the fluid overload. The medication is IV furosemide or IV diuretics. The dosage is 80 mg and this is to remove extra fluid from the body. So the outcome is on 24 November, facial puffiness and edema was reduced at bilateral lower limb after 24 hours. And on 26 November, urination status was improved from no urine output to approximately 1000 ml per day within 3 days. Moving on to the other underlying treatment, which is hypertensive urgency. The first medication is 100 mg of IV metoprolol, 10 mg of tablet amlodipine, 1 mg of tablet prazosin, and 5 mg of tablet felodipine. So the outcome is on 26 November, blood pressure was reduced from 204/101 mm mercury to 136/88 mm mercury within 24 hours. So the next other underlying treatment is for the infection or prophylaxis. The medication given is 13 gram of IV augmentin and 45 gram of IV tazocin. So the outcome is on 27 November, temperature was improved from 37.8 Celsius to 37 Celsius within 48 hours. There are also 2 times of tepid sponging being initiated.
The first nursing diagnosis is fluid overload related to decreased renal excretion secondary to chronic kidney disease, as evidenced by grade 3 bilateral pitting edema, decreased urine output, which is less than 400 ml per day, weight gain of 2 kg within 24 hours, crackles at lung base upon auscultation, and reduced oxygen saturation, which is less than 95%. The goal, patient will achieve improved fluid balance as evidenced by reduced edema, stable vital signs, improved lung sounds upon auscultation, and improved oxygen saturation, which is more or equal to 95% during hospitalization. The first intervention is to assess and record daily weight every morning before breakfast using the same scale and same clothes. It is to detect fluid retention early, as a 1 kg weight increase reflects approximately 1 liter of retained fluid. Next is to monitor intake and output strictly every shift for every 8 hours to note the urine output if it is less than 400 ml per day. It is to evaluate the severity of oliguria and the extent of fluid retention due to impaired renal excretion. The third is to assess degree of peripheral edema to note the grade and the location, and auscultate lung sounds every 4 hours because it is to identify worsening fluid accumulation in tissues and lung, which may lead to respiratory compromise. Next is to monitor vital signs every 4 hours, particularly blood pressure and respiratory rate. It is to detect hemodynamic changes associated with excess intravascular volume. We can also implement prescribed fluid restriction, such as 500 ml per day, and educate patient on its importance. It is to limit further fluid accumulation when kidneys are unable to excrete excess fluids. Nurses also should prepare and assist patient for scheduled hemodialysis with ultrafiltration. For our case, patient will undergo hemodialysis 3 times per week, and we should ensure the central venous catheter dressing is clean, dry, and intact. Hemodialysis is to remove excess fluid directly from the bloodstream via ultrafiltration. Lastly, we can collaborate with dietitian to provide a low sodium renal diet and educate patients to avoid high salt foods. It is to prevent sodium-induced fluid retention, which worsen edemas and fluid overload. The outcome: patient achieve improved fluid balance as evidenced by reduced edema, stable vital signs, improved lung sounds upon auscultation, and improved oxygen saturation, which is more or equal to 95% during hospitalization. The second nursing diagnosis is ineffective gas exchange related to alveolar fluid accumulation, secondary to fluid overload, as evidenced by shortness of breath, hypoxia, which is level of oxygen less than 89%, need for oxygen via nasal prongs at 3 liters per minute, and ABG results showing metabolic acidosis with partial respiratory compensation. The goal: patient will maintain adequate gas exchange as evidenced by level of oxygen more or equal to 95%, reduced dyspnea, and improved ABG results during hospitalization. The first intervention that we can apply is to assess pain level using numeric rating scale 0 to 10 before and after movement or activity. It is to evaluate pain severity and determine its impact on mobility. Other than that, to assess lower limb mobility and strength every shift, including ability to stand, walk, or repositioning in bed. It is to identify baseline functional limitation and monitor progress. Other than that, we can also observe and document degree of lower limb edema, such as the grade and the location every shift. It is to determine how edema contributes to the stiffness, discomfort, and limited movement. Other than that, the intervention is to administer prescribed analgesics such as paracetamol and reassess pain within 30 to 60 minutes. It is to reduce pain to a tolerable level and enabling participation in mobility activities. We can also auscultate lung sounds every 4 hours for crackles or reduce air entry. It is to monitor progression or improvement of pulmonary congestion. Other than that, we can also review ABG result as ordered and inform doctor if worsening acidosis or rising concentration of carbon dioxide. It is to evaluate adequacy of ventilation and respiratory compensation. The outcome: patient maintain adequate gas exchange as evidenced by oxygen level saturation more or equal to 95%, reduced dyspnea, and improved ABG result during hospitalization. The third nursing diagnosis that we came out for this case study is impaired physical mobility related to lower limb edema and weakness, secondary to chronic kidney disease, as evidenced by inability to perform activities on daily living independently and verbalized pain score of 10 out of 10. The goal: patient will demonstrate improved mobility with reduced pain score less or equal to 4/10 and increased participation in movement within hospitalization. The first intervention that we can apply is to assess pain level using numeric rating scale 0 to 10 before and after movement or activity. It is to evaluate pain severity and determine its impact on mobility. Other than that, to assess lower limb mobility and strength every shift, including ability to stand, walk, or repositioning in bed. It is to identify baseline functional limitation and monitor progress. Other than that, we can also observe and document degree of lower limb edema, such as the grade and the location every shift. It is to determine how edema contributes to the stiffness, discomfort, and limited movement. Other than that, the intervention is to administer prescribed analgesics such as paracetamol and reassess pain within 30 to 60 minutes. It is to reduce pain to a tolerable level and enabling participation in mobility activities. We can also elevate the lower limb on pillow when in bed and encourage gentle ROM, range of motion, exercises twice daily as tolerated. It is to reduce edema and improve circulation by decreasing the stiffness and pain. Other than that, we can also assist patients with gradual mobilization, such as dangling leg at the side, standing, then short distance ambulation with assistant. It is to prevent sudden strain and promote safe improvement in mobility. Other than that, we can also provide assistive device such as walking frame, non-slip footwear during ambulation. It is to enhance safety and reduce risk of fall during the movement. And lastly, we can collaborate with physiotherapists for mobility training and strengthening exercises. It is to improve the muscle strength, balance, and functional mobility in a structured manner. Patients demonstrate improved mobility with reduced pain score less or equal to 4/10 and increased participation in movement within hospitalization.